Thank you. I do apologise. I sort of thought afterwards, is the word Antipodes rather pretentious? And I apologise in advance. I just think it's a fabulous word. And I think... Is that fine? I've done all right. Thank you. I don't know if you've seen it. In an earlier life, I studied literature, and I was one of those sad people. I became really interested in medieval stuff and medieval manuscripts. And there's a drawing. I'm trying to remember if it's the Hereford Mappa Mundi, because they used to think people who lived on the other side of the world literally had their feet over their heads. And there is a beautiful medieval drawings of these imagined creatures. Anyway, nothing to do with today's talk, but I just think it's nice. I just like random bits of information, so there we go. Back last year, I was incredibly lucky, and that's not what I'm looking for. I was incredibly lucky, and I applied for a Florence Nightingale Foundation travel scholarship and was awarded one. And the reason I want to share this experience with you, partly because hopefully this is quite a nice relaxing session towards the end of a very busy conference, but I'm really hoping I might spark some of you in the audience to think about doing this. And I will tell you what I did, because obviously it's got relevance to wound care. But also, it was one of the most fascinating, exciting things I've ever done. In fact, last night I was sitting next to Fiona, we discovered we'd both done something. She's also had one. So again, another person, if you ever want to know what it's like to do one of these scholarships. I'll tell you a little bit about the scholarship, because I didn't know about these until it was sort of put in front of me. In fact, my boss from 10 years ago, who I still dog walk with, she had done one in Africa a few years ago, and she said, "Oh, have you ever thought of this?" I thought, "Oh, that sounds really interesting." And I already had some links out with New Zealand, Australia. I was always wanting to ask questions and find out more, and occasionally we'd bump into each other at conferences. But the idea of actually going and spending some time and learning about living in a different culture, but one that is not so dissimilar to our own, I thought could be really interesting. I'm trying to remember the dates. I think these get advertised towards the end of the year. They are on the website. If you are thinking about doing something like this, get organised early. There is a lot of work involved in actually working out, because you can't just say, "Oh, I fancy going to Australia." You have got to, tempting though that is, what you've got to do is come up with a programme. You've got to work out your visits. You've got to work out your costing. So there is a fair amount of work involved. And I would say it was the second most scary interview in my life, apart from my PhD interview, where I got into the lift afterwards and couldn't operate the lift because my brain was so fried and had to be helped out of the building by the receptionist. It wasn't quite as scary as that, but it was a fairly challenging interview. I don't know if yours was similar. Fairly challenging interview, but I must have made a good case because they awarded me the money. And it led to the most fabulous experience, so do look into these things. There are opportunities out there. Do look into them. Right, so what did I do? I mean, I don't need to tell you this as an audience, you know this. We know we've got a problem in Great Britain. We've got evidence of suboptimal care, and that's putting it politely. We know we've got issues around education. I've had numerous conversations during the last 2 days with people who say, yes, we know we need to education. What about the pre-reg education? What about the medics? How do we improve things around the preparation for clinicians who are looking after wound care? And I'm also a researcher as well an educationalist, and I've been involved, many of you will be familiar with the Venus studies that came out of York and Manchester, and I know how hard it is to recruit to patients to studies, good quality studies who work in the community. In fact, I was sitting in the REN programme yesterday, and again, a lot of things are being presented from a hospital perspective, which is great, but we also need research for those of us who are community nurses, and recruiting the community is really hard work. I knew that in New Zealand, they also run some really good trials, which I'll talk about, and I wanted to go and see how they did it, because they will have some tips that we can learn from. So that was what I persuaded the funders that it would be worth investing in. So I wanted to look at leg ulcer care delivery in particular. That's my personal obsession when it comes to research. I wanted to look at the educational needs of the clinicians delivering leg ulcer care. Because it was the Florence Nightingale Foundation, it was obviously more focused on nursing, though my interests are wider than that, but for this purpose it was on nursing. I wanted to look at the mobilisation of leg ulcer knowledge. One of the things we've talked about in the last few days is we know a lot of things. We're not so good at putting those things into practice. And one of the expressions for this is knowledge mobilisation. It's getting that knowledge where it needs to be into practice. And I was interested about how they do that. And I wanted to look at how leg ulcer research is conducted in the community. and obviously identify the similarities and differences so we can learn from each other. So where did I go? Well, I only had 4 weeks because I didn't have much time and I had to fit in as much as possible. So I had visits in New Zealand, and when I contacted my contacts in New Zealand, Andrew Jull was my main contact, who's a professor over at the University of Auckland. He is a lovely man, and when I wrote to him and said, would you be willing to help me sort this visit out? He said, oh yes, come and see us. He said, and in fact, while you're here, it would be great if you saw our beautiful country. So bless him, he set me up with a trip that literally took me all over New Zealand. Well, not all of it, but as much, and you'd be amazed how much I managed to pack in 3 weeks. So where did I go? I started off at the University of Auckland, spending time with the researchers there. I then, I think it's on the same place, yes, well, not quite. I also spent time with some of the clinicians, went and spoke to some of the hospital clinicians at Auckland Hospital. I then moved slightly south to Counties Manukau, got that pronunciation right, which was a community visit with a load of community nurses. We then did a very long trip, right down to the south, down to Dunedin. And again, I went and spoke to vascular services there and worked with some of their nurses. And then I went to Canterbury, which was a completely different service to anything I'd seen before. And what I would say, I saw a real different spectrum of providers, and Andrew had said to me, he said, I'm sending you these to these places because they're very different. And I think if you go and talk to people in lots of different places, you'll learn more, which was good advice. So obviously, the stuff in Auckland was very closely tied to the university and fairly acute what I was looking at. Counties Manukau was probably what I call average. You know, it was typical, maybe. Now, they had their problems, they had their challenges, they had some good stuff as well. Dunedin was vascular services. It was leg ulcer care seen very much through the lens of vascular services. Canterbury was really interesting. I thought they were taking the mick when they told me where I was going, because it was the Nurse Maud service. And my grandmother was Maud, and it's a family joke. She was Great Aunt Maud. She was the family matriarch. I thought they've really got an organisation called the Nurse Maud Service. They have. And it's been around for about 100 years, and it's nurse-led. It's entirely nurse-led. It was inspirational. And Canterbury itself, which was obviously bombed by, the earthquake, I couldn't believe 7, 8 years, that has had a major impact. It's an interesting world that when devastation occurs, you have to rethink how you do things. And although what happened with that earthquake was terrible, what has come out of it in terms of how they've looked at their service has been amazing. And then we moved on to Australia, and we went to Melbourne because I had contacts again at Monash University. I don't know if any of you are familiar, but conversations I'd had at UMA, I'd got to know some people there. Monash University do some superb tissue viability education courses, and I wanted to go and speak to them and see what they were doing. So that was my trip. So I'll talk through New Zealand first, and then I'll move on to the Australian thing. In Australia, I only really looked at education. There wasn't enough time to do anything else. In New Zealand, healthcare, it's not so dissimilar to our countries. Community care is provided by the district health boards, which fund and commission the care that's being provided. Most leg ulcer care is provided by practice nurses, community nurses, which I think is fairly similar, most of us would agree, to what we do here. Interestingly, there's a push away from home visits, but it's towards smaller clinics, not necessarily large clinics with expertise and multidisciplinary teams. It's more about trying to provide care in as close to home as possible. Which is a good thing, I would say, and obviously trying to get patients who can be mobile to be as mobile as possible. I would salute that. Interestingly, one of the things the nurses said to me, while they could see the argument for that, because often these nurses are working in isolation, they're not getting the opportunity for sufficient opportunities for what I would call deliberate practice. You know, when you learn to Doppler, to use that phrase, we would call it a verb, don't we? It's not actually a verb, but there we go. To Doppler. When we learn to Doppler, really what you need to do is you need to learn to do the technique, and then you need to practice and practice and practice, and you need to do it with somebody who knows what they're doing so they can tell you what you're doing right and what you're doing wrong. If you're working on your own, like many of small teams in England are, and you're not getting that feedback, you don't know how good you are, and you're not necessarily sure about how to make yourself better. And they're facing a similar problem over there. So I found that quite interesting. Also, tissue viability nurses don't really exist in New Zealand, which I found surprising. There are nurses who are doing roles similar to us, but they don't have this concept. We are far more developed as a community of tissue viability nurses than they were in New Zealand. That surprised me. It tends to be something that's part of the generalist role, though there are few around, but it's nowhere near as well established, from what they told me, as it is in the UK. Care is guideline-based. Actually, I have to say, their guidelines are more up-to-date than ours. Signer guidelines, brilliant. Thank you, Scotland. We're very grateful to you. But it is getting quite elderly, that guideline now. It needs updating. And one of the things, certainly from the national strategy we're going to be pushing for, we need something updating. The New Zealand-Australian one is currently being updated, but even the older version, I believe, is more up-to-date than ours. But very similar to us. They have a guideline. Care is supposed to be based on it. What I found absolutely fascinating, though, was when I went up to Canterbury, which I say was the most sophisticated of the services I visited, they had an incredible e-management pathway. So the guideline was basically had been incorporated into technology, and it was available to all clinicians working within that health board. So whether you're working in vascular services or community or GP practice or whatever, you had access to the same data. While I was sitting there in clinics with them, they could look up to see what the surgeon recommended. They could have conversations. It was joined up. It was brilliant. They also had localised information because obviously, although New Zealand's quite a small country, it's quite different and it's very rural. So they also, that technology had been localised, so it had the information that was useful to the people working in that locality. There was alignment with e-referrals, so it was easy to get people around the system with joined-up thinking, and it really supported geographically isolated teams. While we were there, there'd been I think it was an earthquake. Some geological events are not unusual in New Zealand. We came back with a very different aspect. You know, in England, you tend to think the ground is under your feet and that's it. It's not like that in New Zealand. Things move all the time, and that was quite a revelation. But of course, that has impact. So quite often, patients who are supposed to be coming through to clinic can't get there. You know, we talk about providing care at a distance. They have this quite regularly. So they have worked their technology so they can support these more geographically isolated teams. Now this one blew my mind. Again, in Canterbury, they have an initial 2-hour assessment for people with a new wound on their lower leg. I said, what? I thought I misheard the first time. But then I thought I misheard again because the nurse I was working with, I said, how on earth do you manage 2 hours? And she said, well, it was a bit of a story. But she said when she came, she was actually an English nurse who moved over there 20 years ago. And she said when she came into service, like she was working in a service, not just like many of us, absolutely inundated with referrals. But she decided if she was going to do things, she was going to do things properly. And if it meant a waiting list, it meant a waiting list. So she did things properly. And of course, because she was working in the nurse ward service, she was supported from the culture that supported her doing that. So if a patient needed to go and see the surgeons or the vascular people, she would go with them because they didn't have the technology then to get that joined up thinking. I have to say she must have had very thick skin and guts, but I salute her courage because what happened was she made such a positive impression on the vascular surgeons and her colleagues in the hospital who had power that they campaigned for the resources to be put in place for her to do her job properly. Now they do not have any waiting lists. She had a 4-year waiting list at one point. I couldn't believe it. 4 years. I thought I misheard, but no, 4-year waiting list. But that came down very quickly once they realised it was a 4-year waiting list and they actually had the resources came about. I think there's a lesson in there for us being brave and assertive about what is needed because I take my hat off to it. She was impressive. And now her patients, her new patients, because quite a lot of the time, because of the geography, her patients will travel quite a long way to see her or see her team. So if you're going to only have that person at that point, if you give them that time at that point, you can do it properly, and then you can start to follow up with more remote working because you've actually got to know each other and you've got a proper assessment. So I think sometimes we rush things, and rushing doesn't help. I think that's actually come out in quite a few presentations during this conference, is making the time to do it properly and having the courage to insist on actually having the time. I'm just curious, I've never had a surgical background, but my impression is surgeons don't have to complete their operations within a certain time frame. I'm sure there must be some guidance, but I don't think, it's not like practice nurses, 10 minutes for appointment, 20 minutes if they push it. You can't do it, can you? You've got to allow the time for what is required. There's a lesson there. we've got problems with obesity in this country. They've got serious problems. The Polynesian culture, big is beautiful, so they have some enormous people come to see them. Trying to do an ABPI on a limb that's out here is really difficult. Now, one of the things I found interesting is they've started doing, what would you call it? Not AB, well, I can't remember what the pulse is called in the wrist, radial, yeah. They've started doing an AR, forgot that, AB, yeah, AR, P, well, whatever it is, it's the radial rather than the brachial. I was intrigued by that because they can hear the radial pulse. Now, the question I asked is, how accurate is that? And they said they've done some, as far as they can work out things, when they've done some initial tests in healthy people, it seems to be a reasonable replacement. I don't know. I think it could do with maybe, and we discussed possibility of maybe doing some studies on that, because I said you really need to do, if you're doing it as a diagnostic, it needs to be done in the population that you're testing it in. You can't do it in a well population because you'll get slightly different results. But it's an interesting idea, isn't it? And maybe that's something, a piece of work that needs to be done. And I've mentioned already about the technology to support assessment. And so they had some wonderful, they were using Silhouette, which is one of many systems that's available. But what they told me, which I particularly caught my imagination, was technologies that captured data that was easy to use, that could be used at the patient's bedside, but also could produce a graph, a trajectory of healing. They found enormously helpful in working with patients to work together, because the patient could easily see, you know, when you look at a wound, you think, is it getting bigger, is it getting smaller? When it's plotted accurately and you can see the line, which way it's going, it's much easier to have that conversation with your patients about what should we do next. So making that data not just visible to us, but visible to the people we're working with really, really matters. And I hope it's encouraging to you. That's certainly something that the data and information team are looking at the moment with the recommendations they'll be coming out for how we collect data. Leg ulcer treatments. It appeared to be the norm that patients turn up for their appointments to have their legs dressed, having been in the shower, taking the bandages off, being in the shower, being given a simple dressing to put over it until they get there, and then they dress the wound. Obviously, it saves time. It promotes patient independence. Patients can get washed properly at least once a week, however often. New Zealand can be, especially in the north, can be quite a warm place. And it just seemed to be the norm and perfectly accepted. I thought, why don't we do that more here? Some of you will, but certainly I don't think it's the norm. And I think it's an interesting idea. It saved the nurses time because they weren't having to take time to do all the cleansing. They didn't seem to have a problem with increasing infection. Why would they? Because, you know, there's no obvious reason. It seemed to work well. The other one that I'm not sure what I make of this. They seem to have an obsession with debridement, or scrubbing the wound, as they said. Now, to me, it looks painful. They have a problem. Again, it might be because of the heat. There are summers are getting warmer too, it seems. That actually, by disturbing that surface, they seem to get better granulation. They thought, again, I'm a researcher. I don't know about the evidence for that. I would worry about what that patient experience is. But certainly talking to, can't remember who I was talking to a few weeks ago, there is some emerging evidence about actually activating that wound bed in some way. I'm not saying that this is necessarily the way to do it. And when they were scrubbing, what they were doing was often just making sure that they'd actually taken some gauze, clean water, and just cleaned that bed. I don't know, but I think it's an interesting idea, and certainly I'm aware those ideas are starting to emerge in the research community as well. What she's doing here, which I don't think we can, is this amused me. I did get permission from this patient. I did say what I was going to use my photos for. This was in our vascular service, and honestly, it was like going into some sort of chemical warfare. She was so gowned up with everything to basically use the water jet, Versajet is it, or that sort of thing, to debride. It was clearly very painful for the patient. I wasn't convinced that it was necessarily do much good, and the time it took and the equipment required. There's no way you could do this in a home setting where most of our patients are. Interesting, but again, when I looked into the evidence, I wasn't convinced by the evidence. Dressing selection. They do have non-medical prescribing, but actually very few people working tissue viability do prescribe or are prescribers. So it's there as a system, but it's not widely used. They tend to work from stock provision, which works reasonably well up to a point, but it's very limited. And sometimes that can work quite well. If it's, let's face it, a low adherent dressing is a low adherent dressing. You know, a knitted viscose, there's not much difference. But when it comes to hosiery, we've all got very different shaped legs. So if you're being limited to only one type of something, that can have its problems. And in fact, it's got even more of a problem in New Zealand because compression hosiery is not on prescription, so it's only what's on the shelf. That's a problem. It's a real problem. And it's a real problem getting people to wear hosiery after their ulcer's healed, because it's not provided after they've healed. So they recognise that's a problem. At the moment, they are working on to make that possible. They know it's a problem, but it hasn't been solved yet. On the plus side, if you've only got 1 or 2 bandage systems to work with, chances are you'll get fairly good at them. So I think there's an argument, whatever bandage system, familiarity. I was involved with the Venus 1 trial, which compared short stretch bandaging to 4-layer. And what they found was in Britain, 4-layer seemed to be slightly better, more effective than short stretch. The trial was repeated out in Canada, and they found short stretch was slightly better than 4-layer. But of course, in England at that time, 4-layer was the most commonly used system. In Canada, short stretch was the commonly used system. Chances are they're pretty similar. And actually, it's the familiarity that makes them more effective. So getting good at something, again, that deliberate practice I mentioned earlier, really matters. Get good at what it is you're using. Am I doing time-wise? Okay, I've got to hurry up a bit, haven't I? Sorry. Compression. They prescribe, in one area, they prescribe in millimetres mercury. And those of you who went to the AND session earlier might note that we're wanting to suggest we should move in a similar direction. The nurse, one of the nurses I was working with, she pointed out that when she first moved over, she was prescribing class 2, thinking it was the same as in England. A year later, discovered it was actually higher than what she was used to in England because it was a different system. She was horrified, but then she thought, well, actually, my patients are doing all right. But I think we do need to be more accurate, so we need to think about that. And I've mentioned hosiery already. Oral medication, pentoxifylline, yes, the evidence suggests it works. Same problems as we have. Nobody prescribes it because of the problems of polypharmacy. Psychosocial care was interesting. These needs were expressed by quite a few patients, and in fact one of them had been online and discovered the Leg Club in England and said, I wish we had something like that here. They really would like more psychosocial support, and I think that's a fair ask. Undergraduate education. Again, I did start slightly late. I can have a few more minutes. Go on. But I will still be quick. Like us, they have a 3-year programme. So that's fairly... This is talking about nursing here. Undergraduate 3-year programme, which leads to registration. However, what they also have on top of that is when they go into employment, and that's assuming they go into a publicly funded post. I don't think it's the same if you go straight into a nursing home, but if you're working for one of the district boards, there is, I say 1 year, I think it's 10 months of required mandatory new entry, they call it the NetP education, 1 year new entry to practice programme. So if you're going, and those programmes depend on where you're going. So if your first post is in a community setting, there will be a programme you're expected to undertake that is funded and that is developed in collaboration with the local university. So it's about practice. And I think it's a brilliant idea. I think it's more than just the mentoring type thing we do. I think it's far more structured than that. And I think it's a great idea. I wish we did that. And it's up to the local needs of the population. So, for example, obviously, if you're moving into community, which was my focus for this study, they'll get lots on wound care. They only get the basics in the undergraduate, but if they're going somewhere they're going to be doing a lot of wound care, they get good training. We were talking last night about different cultural needs. If they're moving somewhere where there's a high Maori population, they get education about being appropriate care for Maori people, and that was fascinating. They don't have a district nursing equivalent qualification, so this is actually quite important because that sort of fills a bit of that gap. Then I moved on to Australia. They have an MSc of wound care. If you want to, I will be brief here because it's online, you can look it up, so I'll whip through. Basically, it's mostly online, but they have 1 week mandatory attendance on campus. And there are optional streams. You can choose to go down a research stream or you can choose to go down a coursework stream, which is basically for those who have no intention of becoming a researcher but want to become a leader in clinical practice. So there are choices within that, which I thought was interesting and creative. It's taught, they have a course director, but the people who teach on this course are experts. They would be hauling in you lot to teach because you'd be recognised as the experts in your field and you would work with the university. So it's taught by people who know what they're talking about but are used to working within the university. Mostly nurses. What I found particularly interesting was pharmacists are very engaged in wound care. I don't think in England pharmacists are generally much engaged. Though interestingly, again, with the national strategy, we're getting heads of medicines management much more involved, and they are interested in what we're doing. So I think that may change with time. I hope so. They get their students from all over, including the UK, which I'm sorry, Huddersfield, I know you do a good course. But there were students who were going to Monash in Australia from the UK to study, which I found interesting. It's a very good course. I'm going to be very quick, aren't I? Sorry. University of Auckland, I've mentioned they are leaders in wound care research. The Cochrane reviews were led by researchers there. They've got 2 trials going at the moment. Aspirin, which found no evidence it made any difference for healing of venous leg ulcers, and they've got another one at the moment with keratin dressings. Andrew did joke with me that the New Zealand government's quite keen on investing anything they can do with local produce, and obviously they produce quite a lot of honey and have quite a lot of sheep. So there are... yeah, we'll put some money to that, it might work. What a lovely coincidence, international travel. I was sitting there chatting away saying, oh yes, there's a New Zealand study I use for teaching research. It's actually nothing to do with wound care, nicotine replacement. I love it because everybody can get their head around nicotine replacement therapy, whatever, because I teach mental health nurses, all sorts of nurses. And I said, and what I love about this study is it is beautifully designed, and so I can teach the principles of RCTs from this study because it's a perfect example. And they said, who's the author? And I said, oh, I don't know, somebody called Walker. Right, fine, right. Who's the Walker? They said, oh, she's sitting at the next desk. How lovely. They've got similar challenges to us. Pragmatic RCTs they do. They've got dedicated researchers. It's always... Now, this should encourage us. Improved healing rates. They are doing so well with healing that they're finding it more difficult to recruit to studies. That's a success story, I would say, even though it's a pain in the backside for the researchers. Things you would expect. The little tear-off strips to patients, make it low-tech solutions is sometimes the issue. So what have I come back with? We need to make guidelines available to everybody who needs to access with that patient information. It's not just having a paper guideline, it's integrating that into our electronic systems. We need to spend more time on early assessment so we get it right, we get the engagement of the patient, and they go out with the right care. We need to get patients referred to secondary care by the clinician with the expertise, irrespective of their profession. Shouldn't just be through the GP gateway. And we need to support community nurses to do stuff. Sorry, I'm going to have to be quick here, aren't I? Telemedicine. I think I've mentioned most of these, actually. I think I've covered these as we go through. It will be available afterwards. We need to look at our education provision. I think I've talked about this in the last few days. We need postgraduate education, we need choices, and we need it to be accessible. Again, I think I've covered most of this and the slides will be available for those of you with an interest in that. Why apply? It's a brilliant thing to do. It builds confidence, it builds knowledge, it builds networking. And I've been able to share this with a huge variety of people, including yourselves. It's feeding in so many different things I'm doing. Lovely pictures. I do like an academic reference. You've got Dr. Seuss. Seuss, is it? I don't know how to pronounce it. Dr. S.E. Yes. I thought, nice academic reference. The more you read, the more things you'll know, the more that you'll learn, the more places you'll go. So true. Keep reading, keep learning. And finally, I just want to give a thank you to the support team who got me there. Florence Nightingale Foundation, obviously. School of Healthcare, my colleagues who helped support my students while I was away. And my support crew, my husband who's sitting at the back, who was who got me from A to B, safely, on time and fed. And that was my office on the right for the weeks I was away, sitting in the back of a camper van, typing away. Thank you very much.